Hello, my name is Guy Young. I'm from Children's Hospital Los Angeles and University of Southern California, Keck School of Medicine. It's my pleasure to talk to you a little bit about some very recent data that was published regarding the valoctocogene roxaparvovec factor VIII gene therapy, in this case for patients with active inhibitors or for patients with a history of inhibitors. So, as you know, valoctocogene roxaparvovec has now been licensed in many countries as a factor VIII gene therapy treatment. It is an AAV-mediated gene therapy, and you can find the results for various trials already published. The intent of this study was to evaluate patients who have an active factor VIII inhibitor and patients with a history of a factor VIII inhibitor. The reason is those patients were excluded from the previous trials. Now you might ask yourself, why would I treat a patient with an active inhibitor with gene therapy? How is that going to work? Well, the reason is that in animal models, it's been shown that gene therapy for animals with active inhibitors to factor VIII, also to factor IX, can result in immune tolerance. In other words, the endogenous production of factor from gene therapy can have a tolerizing effect on the immune system, essentially teaching the immune system that factor VIII legitimately is being produced by the body, and therefore to stop making the inhibitor. So that's the premise of this clinical trial. So the design of the trial is it has two parts. Part A, which is for patients with current active high titer factor VIII inhibitors, and Part B for patients with a history of inhibitors. For Part A, all patients are on emicizumab before they enter the trial, because that is the standard of care for patients with factor VIII inhibitors. For Part B, patients can be on factor prophylaxis or on emicizumab entering the trial. The design of the trial is that patients receive one dose of valoctocogene roxaparvovec at the usual indicated dose from the package insert, which is 6 × 10^13 vector genomes per kilogram, and the same for Part B. In the presentation today, I'll be discussing 2 patients who enrolled in Part A and 2 patients who enrolled in Part B. In this study, in addition, patients were on prophylactic corticosteroid medications, so prednisone was given prophylactically. So if we look at the results of this trial, we're going to go through each patient one by one. So the first patient in Part A was on emicizumab prophylaxis, received his dose of valoctocogene roxaparvovec, and had a rise in his inhibitor titer initially, and then it dropped. This is in fact what we expect to see. As the body starts producing factor VIII, we expect that the inhibitor titer will in response rise, as basically you're giving more antigen to the immune system. But that over time, the inhibitor level will then go down and hopefully disappear. In the first patient, he had an up and down course with his inhibitor titer. He never got a factor VIII level that was measurable. And we think part of that is because he was on and off corticosteroids a few times because he had increases in his ALT and increases in his AST. Finally, he did get off the steroids, and in the last few months, he's had a rapid rise in his inhibitor titer, to the highest point actually it's ever been. We think this may mean that his body is now producing factor VIII at good high levels. And we hope that this rise in the inhibitor titer is what we see when we initiate immune tolerance, and that ultimately it will eventually fall. But of course, we'll have to wait to see if that is the case. The second patient in Part A responded better. He had a rise in his inhibitor titer. It plateaued, and then it went down and continued to go down. After about 9 months, he had a rise in his factor VIII antigen, followed by a rise in the factor VIII activity once his inhibitor disappeared. And then he was able to come off emicizumab, and he now has a factor VIII level of about 15%. He's almost a year out, and we're going to continue to follow him. The Part B patients are a little bit more straightforward. They have a remote history of inhibitors many, many years ago, and they were already tolerized. So we expect that they would respond like patients without inhibitors, with a rapid rise in their factor VIII level and ongoing factor VIII levels over time. And that's in fact what we saw. Both patients had a rise in their factor VIII level within a few weeks. That factor VIII rise was sustained over time, and they were able to come off their factor VIII prophylaxis within about 4 to 5 weeks. They continued to have high factor VIII levels. However, one patient did have a rise in his ALT, necessitating reactive immunosuppression. He actually received mycophenolate instead of steroids for the reactive immunosuppression. His factor VIII level did go down a bit after that and then eventually stabilized. One of the patients, this one, has a factor VIII level of about 10%. The other patient, at about 40 weeks, has a factor VIII level of 75%. He never had a rise in his ALT. So basically, to summarize, what we have found is that valoctocogene roxaparvovec can have a tolerizing effect in one of the two patients so far we've seen in patients with active inhibitors. The other patient with an active inhibitor has had a rapid rise in his inhibitor titer recently, and we're hoping that that indicates that he may be tolerized in the future. The Part B patients, who are those with a history of inhibitor, have responded in a manner very similar to patients without inhibitors. And so we expect that future patients with a history of inhibitors but no active inhibitors should respond to valoctocogene roxaparvovec like patients without inhibitors. In terms of safety, ALT elevations were seen in 3 of the 4 patients, similar to what was seen in the main valoctocogene roxaparvovec trials. In the patients with a history of inhibitors, there's been no reactivation of their inhibitor, so we're happy to see that. There were no other serious side effects for any of the patients, and the study is ongoing and is intended to enroll 10 patients from Part A and 10 patients from Part B, and we hope to have many more patients enrolled in the coming year and hopefully conclude the study within a few years. Thank you for listening, and hope you learned something interesting.